I think in the modern era of PE management, there are a few parameters that needs to be done in every patient, and it is troponin. You can have also NT-proBNP, but I think troponin
is better.
Troponin is needed, and then you need lactate. Lactate is very easy, and it's a very good marker of shock. And then you have vitals, and with these three items, you have most of the decisions parameters you need. And beyond that, you can do a proper echocardiogram to find further information on right ventricular dysfunction, and you can do a lower limb echocardiogram to look for proximal DVT. And I think with this information, you have everything you need to know to make the decision on anticoagulation or reperfusion, and then which kind of reperfusion. Are you going to give thrombolytics, or are you going to go for local thrombolysis, or are you going to mechanical thrombectomy for a very early recovery and a very efficient and safe procedure? What we did is we tried to go a little bit beyond the guidelines, just because they are a little bit old. They are 4 years old right now, and there is a lot of evidence that we have now regarding risk stratification, non-invasive shock. So this means that there are some patients with intermediate to high risk that has some shock parameters, and actually when you measure invasively the cardiac output, you can see that it is decreased. And also we have a lot of information regarding safety and efficacy of catheter-directed interventions and mechanical thrombectomy, and we know now from registries with hundreds of patients that we can perform mechanical thrombectomy in a safely and timely manner with less than 2% of procedural related complications and with very low mortality, below 1%. Let's say we get a call from the emergency department, we get this PE diagnosis, and we look for risk stratification, and the patient has right ventricular dilation, so RV to LV ratio over 0.9, and the patient has positive troponins. We ask them to bring lactate levels, and then we admit the patients for monitoring maybe 24 or 48 hours. And which are the parameters we are looking for in terms of deciding we will leave this patient on anticoagulation or we will take this patient to the cath lab?
The variables we are looking at for the intermediate risk patients are lactate over 2, shock index over 1, and syncope. If the patient has one of these parameters, he would benefit from thrombectomy. He's a good candidate for that. If the patient doesn't have these variables but still has some others like right ventricular dysfunction, saddle thrombus, PAFI less than 250, deep venous thrombosis, and oliguria, he's also a good candidate for reperfusion, and we could schedule the procedure for the next morning.
So when the patient comes with blood pressure below 90, we will call the acute coronary care team to stabilize the patient if possible, and then we make a decision based on A, do the patient have contraindications to thrombolysis, and B, do the patient have a very high bleeding risk with thrombolysis. Also, if the patient has thrombolysis, so if the patient has systemic thrombolysis, the patient goes to the acute coronary care unit, it is monitored, it receives hemodynamic support, and we wait 2 to 4 hours for a response after systemic thrombolysis. If we consider that the systemic thrombolysis response is not enough, if the patient is not improving, we will consider taking the patient to the cath lab for a rescue mechanical thrombectomy.
30% of patients have contraindications for lytics, so they are good candidates for reperfusion. Although you have the extreme patient, the cardiac arrest patient, you can't perform the thrombectomy, you have to put the patient on ECMO first. But then I would like the alternative, ECMO plus thrombectomy. I think that's a good option for the patient, because if you put the patient on ECMO, giving lytics is like it makes a very high bleeding risk for this patient, so I think the option of thrombectomy is much better for this patient.